clinical research in cerebral palsy. My name is Paul Gross. I'm the founder of the Cerebral Palsy Research Network. I'm joined tonight by Garey Noritz, who is at Nationwide, is a co-founder of the Cerebral Palsy Clinical Research Network, and is also the medical director of their complex care program. He's a developmental pediatrician there. And we'll be joined shortly by Jeff Hoffman, who is the Chief Medical Information Officer at Nationwide Children's Hospital, to provide us some more deeper technical detail on what it takes to implement this type of system within Epic as an EMR, as a mechanism for collecting clinically relevant data that can then be used for clinical research. Okay, so a couple housekeeping items real quickly. This session is being recorded. The speakers will come off mute as we go to speak. When we get to the Q&A session, which we're going to hold till the end of the speakers, we've actually pretty proactively tried to plan to answer your questions that you wrote in advance as part of the presentations that we're doing. We will then go into a Q&A session, and we're going to have you write questions into the Q&A box as opposed to attempting to have people speak and deal with different microphones and echoes and the like. So if you could hold your questions till Jeff Hoffman has completed speaking, that'd be great. I think we'll have answered a number of questions, but I'm sure we'll have plenty of time for some interaction. Okay. So let me see if I'm able to advance my slides here. I am. So the Cerebral Palsy Research Network was really announced at the American Academy for Cerebral Palsy and Developmental Medicine in October, but we've been working on it for quite some time. I'm not going to spend a lot of time going into the background. I'm going to give a little bit of status of where we are, but not go into the background of sort of how we got founded and the path that we're on. Let me just start by saying our mission is to improve the treatment and outcomes for people with cerebral palsy through high quality clinical research and quality initiatives. You might have some questions about that over time, but essentially we're going to invite several institutions and clinicians and therapists together to collaborate on important research questions and collect the same data at all of our institutions and pool it together at the University of Utah and use that for the basis of planning clinical studies and research initiatives. I see this build, so let me see. Jenna, I'm just going to ask you in the background, I see this slide must be a build, and so I don't know what I need to do to get it to actually build. So if there's something you can do to get you can build out all the bullet points if you would for me, that would be great. I'll tell you when you're done. That should be it. Okay, so where we are is the definition of our registry, which is at the core of CPRN, is complete. And when I say it's complete with the first pass. We engaged over 30 clinicians and therapists starting really in late April. And the direction we gave people was that what we wanted to do was ask for what were the minimum set of clinically relevant data items that you touch on in the course of a clinical visit of a patient with CP that are important for characterizing the patient and characterizing their interventions. And then ultimately, what do we think are the most important patient-reported outcomes? And so we try to keep that in mind the whole way through, is which ones were clinically relevant to that characterization so that we could then understand the patient populations that come through these different centers and the practice variation between them, and use that as a basis for planning studies and planning quality improvement. We've defined approximately 400 fields. I think it's sitting at about 427 fields. 135 of those are patient-reported outcomes or patient-reported data. We have a number of items that are patient-reported data about their physical therapy and about the devices they use. So it's really about 292 clinically relevant fields. And of those, we have about 85 that would be collected between our non-surgical practitioners, so developmental pediatricians, pediatric neurologists, and physiatrists. It's actually 61 to be collected by them, and 24 by PT and OT, and then 21 that are demographics. So those are the so there's only about 85 that would be collected on a regular basis with a clinic visit. And then we've got about 94 that have been defined for neurosurgery over the 2 primary neurosurgeries, and 113 that have been defined by orthopedic surgery across a very broad armamentarium of orthopedic interventions. So those will only be entered from an event basis perspective. We have lots of plans for providing these data elements to everyone to be able to review and have input to, but we've done a lot of internal review with the 30+ people that have worked on defining them. The Data Coordinating Center, or DCC, which is based here at the University of Utah, and I say here because I happen to be sitting here today, is funded to create and manage the registry. So for years to come. So that's an essential piece of this puzzle. And then one of the things that's very fundamentally different about CPRN is trying to collect data for a registry, not by having a clinical research assistant, but by having the data be collected as part of the clinical practice by the clinicians that are interacting with the patients in the form of forms in their EMR, and hence the topic of tonight's webinar. So we're planning on doing front-end development at this stage in Epic and in Cerner. And the Epic front-end is being developed by and donated to anyone that wants to leverage it by Nationwide Children's Hospital. And they've been doing work in this area for several years. And Dr. Noritz is going to take us through that. The EMR front-end development is starting imminently. We are just scheduling our second meeting with Nationwide to review our second review of our common data model. And they have a clear plan for what they need to do to update their existing registry forms that they've built and support this effort. And then I had a great call with Boston Children's this past week, and they are committed to doing this for Cerner and being able to share the results of what they do in Cerner. In terms of charter membership, Jen, I'm going to ask you to expand these out for me. So by charter membership, I mean, what are the sites? So we have 18 sites that are potentially participating in a PCORI grant, but what are the sites going to do that are going to come and contribute to this registry before any other funded study is in place? Well, what charter members are going to do are they're going to be on a biweekly phone call where we advance the fundamental work of the network. And there's lots of work that needs to be done. We need to establish what consent models can work at different institutions. We need to bring study questions to the table to prioritize the most important studies and then validate them against the data that we're collecting in the registry to understand whether or not we would be set up to sort of plan for future studies. We have to define a manual of operations. So what are the standard operating procedures and governance model for the registry? And of course, most excitingly, pilot the registry. So I've been talking to many of you that are on the call, lots of interesting discussions, lots of progress getting your IT staff, your CMIOs committed to this process. And we are going to be announcing who's going to be joining us at the table in January, and trying to create a mechanism by which those of you that can't join us initially can at least stay plugged in, can listen in, and can contribute. So with that, I'd like to turn it over to Dr. Garey Noritz from Nationwide to really give you a walkthrough what this is all about.
Hi, this is Garey. I'm hoping everybody can hear me now. And I'm just setting up my computer here so that everybody can see it. Okay. So we've been doing this for actually since before I arrived at Nationwide Children's Hospital, which is 5 years ago, to really capture what we're doing in the clinical realm into a workable database that can be used for research, quality improvement, as well as clinical care. We've termed this Learn from Every Patient. We presented this at the American Academy before. Start with, I don't have any disclosures related to this, but what we noticed, and what I think everybody's starting to really realize, is that there's a whole bunch of things coming together right now that are really making this the wave of the future, let's say. If everybody's not already on electronic health records, they're soon going to be on electronic health records. There's a great interest in prioritization of translational research. And of course, there's a need to control healthcare costs. And so for several years, there have been multiple editorials calling for what's called a learning health system. And that is that I'm sure that most of the clinicians on the call with me have shared this frustration that they spend a lot of time entering data into a computer. It's helpful for billing purposes. It might be helpful for clinical purposes, but it takes quite a bit of time. And once the data goes in, it's very difficult to get anything out to understand how your patients are doing or how you are performing in practice. And so this new concept of the learning health system is what we've tried to create with the Learn from Every Patient model. And so I'm going to take you through this little cartoon that shows us what this looks like. I don't think you can see my cursor move, but I will tell you that in the top left corner, right now, what I hope I'm doing in my clinic, and what I hope all of you are doing in your clinics, is providing evidence-based standardized care. With that, we are starting to collect the data in a discrete fashion such that it can be dumped into a data mart. And from that data, we can then do both translational research and quality improvement projects to further improve the care that we give to all patients. And then we're back at the beginning, doing hopefully a better amount of evidence-based standardized care. What our model is like, and I'm going to take you through it very quickly because it's what you do in your institution is just as good and just as important, and our overall model of Learn from Every Patient can be used really no matter what you're doing. But just so you understand how we do it, we have an interdisciplinary CP team with representatives of all of these specialties that are listed here. The patients come in, they stay in a room. Each one of these people come in and see the patient, examine them, make a plan with the parent, and at the end of the clinic, we put together an interdisciplinary care plan and intend to follow it out for the next year. This care plan goes to the family, goes to the PCP, goes to the school. We also provide care management for all of the patients that come through this. And then individual services make their interim follow plans. And so they're seen once a year in our team clinic, but the phys med doctor may see them every 3 months for Botox injections. The orthopedist may see them at the 6-month mark for a repeat x-ray. The physical therapist may see them weekly for therapy. Each one of those things is decided. But then there's this annual sort of signpost in the clinic. In order to do the translational portion of the research project and the clinical piece, we first developed a list of all the data fields that we felt were needed to document a clinical visit, as well as the research questions that we felt were needed to improve the clinical care that we give. And then we put together all of these data research fields that both clinical data and research data. And these are all in flow sheets. And so together in Learn from Every Patient and Nationwide, we had about 250 data points that we collected each visit. And for us, we did a lot of standardized testing. We really focused on this as a way to see how the patients are doing over time. And so the big ones that we do are the GMFM for physical therapy, the Quest for occupational therapy, and so on. Now, we've already done a bit of this through the CP Research Network with all of the people that Paul was talking about. And we have the 427 or so data elements. An important point is that these are all not filled in by any one person, and each person should have a manageable amount of data elements. And more importantly, not just a manageable amount of data elements, but the data elements that the individual practitioner would think that they need in order to provide good care to the patient. These all are built into Epic in the form of flow sheets, and I'm going to show you this. And this data goes from the flow sheet into an enterprise data warehouse, which, before that, right in Epic, the data is used to construct the clinical note, and then the data goes to the research database. So our institution at the time that this was created said this is research and you need to consent people to be part of it. So we offer consent to everybody that comes to the clinic. If the parents don't give us consent, we still use the same forms, we still do the same care, just the data is excluded from any data analysis. We also have a database manager who's a physical therapist who is able to listen to the team meeting at the end of the clinic, review what's been put into the child's health record to make sure that it's complete and accurate and consistent. And we thought that to have somebody who really understands the subject matter, as in a physical therapist, was really important. And as far as CPRN goes, we're still exploring whether we're going to need or use both of these issues. And that's one of the questions that I think we'll cover a little bit later. But we don't have a decision on that yet. So what I do in clinic when I go there is I write a clinical note using standardized data entry. And I'm going to switch over to the Epic Playground, as they call it, and show you a simulated patient visit. And so if I walk into a room, I'll have opened up the chart and start writing a note using the note writer. Now, in addition to being a big fan of standardized data entry, I'm also a big fan of really understanding the family's story and really getting a flavor of what's going on with the patient. And the place that I do that is primarily in this free text piece right at the top, where I talk about what the family's questions are for the day, or what are the things I want to talk about with the family specific to this patient. And so while I have come in and greeted the patient and schmoozed and asked how things are going, I'll start to gather some of this history. And I'm somebody who types at the same time that we see the patient. And so I might, for instance, be talking that constipation has gotten really bad, despite daily use of Miralax. And then often later I'm going to have to go back and work on my grammar and spelling and things like that. And I could also say sleeping is much better since starting melatonin. So just as a for instance, these things. Yes? Okay. Thanks, Paul. And so this may be the sort of HPI part of the history. I then would switch over to the flow sheets to make sure that I've covered everything as part of my discussion. Some of this I already know from having seen the patient before. Some of this I need to confirm with the family. But, so for instance, I will say that this is a follow-up visit. This database consent, that's actually filled in later by somebody else. But, from having seen this patient and reviewed the record before in the MRI, I would know that this patient was premature, has spastic diplegia, has this item right here called other neurodevelopmental diagnosis that I think is important, because if somebody has something that's, let's say, CPN something else, like somebody with Down syndrome who also had a stroke and has CP, they're in some ways different from other people with CP. And so this is an opportunity to sort of, have a little tick box that says, let's not include that particular patient in most of our research. And this patient has a G-tube and doesn't have a Nissen and does not have any reflux and does not have drooling. And I'll just stop there for the sake of brevity. When we go back to the note and hit refresh, all of the things that I've just put in are now pulled into the note. And so you can see that my note, which I write as essentially an educational document for the primary care doctor, has some basic information about cerebral palsy and then specific information from this particular patient. And then it goes on, and there's other things which we hadn't quite gotten to. So that's essentially how the visit goes. I then usually examine the patient, make my plans with the family, write the orders, and then at the end of the visit, finish up my documentation from the flow sheet, anything that's left over, the review systems tab, and the physical exam. And you don't have to use these things, but it's helpful if you want to be able to pull things out discreetly later. I'd say it takes me somewhere on the order of 5 minutes, no more than 10, to finish the note once the patient has left the room. Okay. So, and just very briefly, I want to say that we have studied what we do, and we've compared our group, the Learn from Every Patient group, to themselves at an earlier time period and to another group of patients with CP who don't get care in our clinic, and they're pretty similar patients. And we, at the time that we implemented Learn from Every Patient, we added another clinic. We increased the number of patients we saw in each clinic. We were tracking the amount of time we spend in the clinic for each patient, and the time went down after we implemented Learn from Every Patient. We asked the providers, does this make your life harder? Does it make it easier or no difference? And 10 out of 11 said the documentation that we had put forth in Learn from Every Patient made it faster and easier. The 11th person said, no, it's really about the same for me. And there was not a whole lot of cost in doing this. And in the first year, we were able to show a reduction in total healthcare costs of charges of $1.3 million. And so here are some very nice graphs that say, hey, we were able to decrease the amount of admissions, the number of inpatient visits, emergency room visits, and costs, and so on, somewhere in the order of about $10,000 per kid that we see in the clinic. Now, we don't think that this is necessarily because of the Learn from Every Patient project itself, but what we did as part of Learn from Every Patient was really try to standardize everything we do for the patients, implement a proactive amount of care coordination, and collect research-level data at the same time that we're providing clinical care. So here are some questions that I commonly get and that I received as part of the pre-work for this call. How did you get buy-in from the providers? So, I think this is interesting, and I think it's really important. So first of all, we used an open process. We went to all the providers in our clinic and said, what are the things you need to know to take good care of this patient? And what are the things you think you need to know because you are an expert speech therapist or nutritionist or whatever it is that would help us answer some of the unanswered questions about patients with cerebral palsy? And in the same vein, what are the things that we could do to improve the quality of care that we give? And so we put it to them to say, what are the things that you want to see in this database? And so we said, what are the questions that we want to answer? And we started and worked backwards. Now, another important thing is that the clinician in clinic, if for whatever reason they don't feel like answering a particular question, or they're less interested in a particular topic, or for whatever reason they didn't get to it with a particular patient, they can just skip it, and that's totally fine. That's just it's a null box, and it's too bad that we don't have that information for the overall thing, but it also keeps the clinician moving on the things that they think are important. And we also are committed to revisiting this regularly. So about every 2 years, we sit down and say, are we really going through all these things? Are these the way that it's of capturing these things that we think are important? And we're right about a time for another iteration of this, And our next iteration is going to be the common data model that we put together with the CP Research Network. And so we're going to be instituting that pretty soon. How long does it take to enter the data? Doesn't it reduce efficiency? We really think it's quicker than typing freehand. If you're used to using paper with a table, let's say, of joint angles where you fill in numbers of joint angles and things like that, it's probably about the same once you actually get the right form up on your screen. And if you don't know where to find it, those first few times it is going to take longer than just pulling a piece of paper out of a chart. And so we've not actually studied the length of time for documentation, but at least 10 of the 11 docs or clinicians in the clinic perceive that it's actually shorter. How are clinicians trained to use the flow sheets? For those of us who were experienced Epic users before this started, it was really very quick. And for people that aren't Epic users, we think it's actually a quick way to learn and jump into Epic documentation. Can data be accessed in real time to view clinical trends? The answer to that is yes. And so here's an example of an actual patient from the clinic where I pulled out 2 different years of their ranges of motion and their GMFM measure. And you can see what they did over time. Can data from previous visits be pulled forward to the current clinical encounter? We don't currently have this functionality, but Dr. Hoffman assures us that we're going to be able to have this in the next iteration of Learn from Every Patient. And one of the questions we'll need to answer is, well, what's appropriate to pull forward and what isn't? How do the data points end up as a useful clinical note? So you saw my note template, which is sort of long and involved and has references and in many ways might be considered pretty academic. Your note template can be customized at each institution, and it can probably even be customized at the level of the provider to really speak in the provider's voice. But the common data elements, those data points can get pulled in. And so it's however you want to state that, this patient has GMFCS level 2, your sentence is however you write your sentence, and then the numbers 1 through 5 get pulled in. Can data points be added that aren't part of this data model? And the answer is yes. This is really a minimum data set. These are the things that we hope we'll be able to provide, collect as part of the CP Research Network. But it really is a minimum. And so if there are other things that you in your clinic are very interested in collecting that's not part of the common data model, you can do that. So for instance, I'm interested in bone health, and so I collect data about fractures and bone density scans in a discrete way so that I can do that, so I can look at things like that for my own research. So here's our conclusions, and our experience has been that it's feasible to create a learning healthcare system at the same time that we're actually getting more kids through the clinic. Those kids that came to our clinic had a significant reduction in healthcare utilization and costs. We think this is primarily a result of standardization of care and our proactive system of care coordination. We saved a lot of money, and most of our kids are covered under our hospital's accountable care organization. And so this is really very useful and delicious, shall we say, to our administration to say, hey, we invested this little bit of money and we were able to keep kids out of the hospital, improve outcomes, and spend less money. And all this clinical data that we've looked at is collected during billable clinic visits. There isn't something extra that we're doing that's collecting the data. And so it's really, we think, a learning health system. The data is collected as part of our everyday work. Here are some questions that I'm going to stop talking for a minute and let Jeff Hoffman give some pearls about these things and some opinions about these informatics kinds of questions. Are you there, Jeff?
Yes, I'm here. Thanks. So thank you for letting me participate in the webcast. I wanted to go ahead and cover the points that Garey was talking about. It's been quite a journey to work through this project from the concept of learning from every patient to the actual implementation. So I want to go through these questions that we have. So the first one is a compliance issue with clinical personnel collecting research data. You know, this is a very different model of data collection. You know, the traditional data collection in research involves separate research collection, data collection tools collected in a different database. And what it involves is, in this case, we are collecting data in the course of clinical care. So the data itself is not specific to research or quality or any specific question. And so if done well and done within the workflows, it is possible to collect data from untrained, unskilled data collectors and still have it be meaningful. That said, there are some issues that creep up as part of this. The first issue being that it can be difficult sometimes to distinguish whether or not the data is clean and clear. You know, in a traditional research framework, you have specific questions and you have an answer for every question. Because questions can be skipped, there's always the question of, is the data not there because it was just not present in that patient's history or because it wasn't collected? In dealing with the research community over the past couple of years and dealing with this question, it is one that I think we need to spend some time with as a research community, trying to figure out how to handle this real-world situation now with data collection during clinical care, where you have to distinguish or assume that your clinical staff are collecting relevant data, and if the data is missing, it's because it's not appropriate for that patient rather than just missing data. So the classic concept of missing data and percentage completion don't really make sense in a learn from every patient world. And we can talk more about that if folks have specific questions. Can data be collected via a tablet? So certainly yes, we do allow for our EMR to be presented to clinicians via a tablet form factor if they choose to use that. There's obviously real estate issues when you go down to small screen sizes. We have not yet implemented, at least for the CP project, patient entered data via a tablet or patient entered data via a portal. We have done that with some other groups in pilot projects, and so that's an area we can certainly investigate. But this data, patient-reported data, can certainly be collected from the patient or the patient's family through electronic means, either through a patient portal, either fixed to a computer workstation or mobile on a handheld, or it can be done in a clinic space via a tablet form factor, and that's something we certainly want to investigate into the future. How does the EHR and research database interface? Well, this is the nice thing about Learn from Every Patient. It is actually the same database. It's collected in the same way. Well, it is the same thing. The only difference is that when the information can be de-identified and ported over to a cohort tool, which is what we do for cohort identification, but the data all the way back to the patient's clinical record is intact. The cost of implementing EHR. Well, Garey pointed to the cost of Learn from Every Patient program. That cost actually did not include, in our case, EHR work from the standpoint of implementing the data collection tool, designing it, putting it out there, maintaining it. Our model is that all clinical content is part of our normal IT operating budget for our EHR. So all the analyst time, the physician informatics time, the technical time, that's all part of doing business in our shop. Now, Garey could probably speak to any research-related costs he might have incurred in terms of setting up the research aspects of it. But in terms of the EHR itself, that's our model. Now, I don't know if everybody has that model, whether they have chargeback or cost reimbursement models. But that's, you know, basically we didn't have to rely on any kind of external labor. We didn't have to rely on the vendor. We didn't have to rely on consultants. So that allowed us to control our costs. As far as rebuilding this form or the other content across institutions, I think that's going to be dependent on what platform you're on. If you're on an Epic platform, then we have the capability of sharing all of this content, including all the flow sheets, any forms that would be created, any note templates, any data elements, reporting query logic. with other sites, and we've done that on numerous other projects, and it's very efficient to do it that way. For non-EPIC sites who are interested in participating, it's going to be the issue of local resources there to rebuild or build out tools in their system using their capabilities, using the data specification that we have, and be able to report that data back in a structured way for sharing. I know that, for example, Cerner has dynamic documentation that allows for some of the same pull tricks that we use in getting the discrete data into Garey's notes, but I'm not as familiar with many other systems to be able to speak to that. And the last bit about sharing information between sites. For sites that are not all on the same EMR platform, the most expedient way of sharing data is to settle on a common data set. I don't know how many in the audience have an informatics background, but there are standard terminologies used in clinical informatics. For example, SNOMED is a common terminology used for diagnosis and assessments. LOINC is a standard terminology for lab results and clinical like values. RxNorm is a standard data set for sharing medication information. And so if we had multiple different EMRs out there in this network, all of us settling on that same data standard would help us share our data and preserve the meaning or the semantics of the data. If we're all on a same vendor, then we can use the vendor-specific identifiers to know what field represents what, even down to an identification number or concept behind the scenes. So that answers these questions in sort of global terms, and then I will I'll open it up for the additional questions.
Yeah, so we're going to ask people to use the Q&A sort of chat feature to post their questions rather than trying to deal with additional microphones. So feel free to type in a question there, and we'll parse it out to, or have whomever makes most sense to answer it sort of just jump in. I will say one person had asked, and I didn't address it in my talk, about what do they do if they don't have Epic or Cerner. So for now, we're going to focus on those two EMRs and get people online with that. You know, if we get the PCORI grant that we've put in a request for, we will be building, you know, probably a REDCap type of front end, but that will also assume that you've got clinical research assistants to put in data, and core to the network is that that is not an expense of the network. So that might be something someone could still pay at their institution to enter data into those web forms. But we wouldn't have the sort of the benefit of this mechanism. So Jenna, I am not seeing any questions, and I can't believe that this is a shy group. So I'm wondering if there's anything we need to instruct people on to have them be able to enter a question.
I see a couple from Ed. If you switch over to, what is it called, presenter.
I see them now.
Ed says,
if a spot.
Ed Herberts, if a provider organization wants to suggest a change in the data collection document, what mechanism will they have? Is that through telling the PI me and then through our meetings?
So I guess my question would be, is it about a change in the data, the common data model that we've defined, or is it about what you want to collect within your clinic setting? And so I'm going to answer both of those. I mean, I think that as Garey emphasized, it's a minimal data set. Okay, thanks Ed for clarifying that it's the CDM. So yes, we plan to further, so although we've done a bunch of cross-functional reviews, one of the first jobs of the group will be to take the aggregated set and take another look at it. So we plan to do that, and it would be worked through the PI. The plan is we're going to go some period of time on the pilot before we revisit the set overall, unless we find something sort of fundamentally broken, and then sort of step back and kind of garner, figure out what we've learned from this and what do we want to change, and try to do things kind of in bulk, as opposed, given that there's a ripple effect through multiple front ends. We want to be sort of thoughtful about how we stage this. Garey or Jeff, I don't know if you have anything else you would add to that.
Well, I think my comment is that we expect that we haven't really used it yet, at least not this data set, and so we're going to have to use it, and we're going to trial it nationwide and get our sense of how it goes. But I expect that there are going to be changes. I think that's part of the fun of this is seeing what really works in real life.
I would think from the technical side, I think I speak on behalf of all my colleagues nationwide, we generally would not want rapid change necessarily to embedded electronic tools in our EMRs. At the same time, I think maybe it makes sense to have a scheduled release idea, and we've done this before, where we say we're going to do bi-monthly or quarterly or whatever we decide, to say we're going to release the new specification or the new data tools to share, to implement, and sort of handle it that way. That way people know when to expect changes in their system, and also know when the next cycle is up for changes. Obviously, if there's breaks or fixes that need to be done in the meantime, those are issued as they're found. But I think that model does tend to work well, and just to find a time frame that is appropriate for the level and degree of change you're expecting.
Okay. Well, I'm going to follow on from Ed on this before we take. And so, Jeff, can you see Ed Hurwitz's question there about Garey addressed the concept that we would be able to do this, but I assume it's a site-specific thing. So if you were to hand them a form that collected 20 data points and they wanted to collect a 21st data point, I assume that's totally within their control to be able to do that.
Yes. So, I think the tools that we issue will be able to be customized potentially. I think we have to work through how we want to do that logistically so that updates don't overwrite the local customizations. That's been an issue in the past. I think that also the issue with build time all has to do with how we package this up. I think for sites that are sharing the same tool set, so Epic sites, for example, we would distribute that in a way that could be potentially imported and inserted into current builds, so it's not as labor intensive as building it from scratch.
Well, and you have given some insight into well, I guess your example doesn't generalize because you already have it established, so that doesn't. I'll retract my softball question. Okay, any other questions? We still have.
There's a question from Paresh about estimate of the build hours for the project. I don't know
I think
that's what Jeff covered.
Right.
Okay.
Yeah. I think that for Epic sites, the idea would be that they would be able to receive a package of build that would be installed in their system. So the amount of time to install, test, validate that should be quite a bit less until we know the final data specification and the final next iteration of tools. It's going to be a little hard to estimate exactly how much time it would take to do that, although that is something that we would be able to pilot with doing our own local installation to see how long it would take, and it depends on the technical expertise of the site. Then we'd have to decide if we're going to be, how we're going to offer technical assistance for installation if they run into trouble, and how much Epic is going to be involved if it's an Epic site in doing that. For the non-Epic sites, I think we have to look at that and see what their ability is to share between each other. So if one site is able to build say, a Cerner tool package, would Cerner be able to lift that and put it in another institution's instance or not? I don't have an answer to that question.
It's my understanding there can be some sharing there. I don't remember all of the details there, but we'll explore that as we get a little further along. I know both Seattle Children's and Boston Children's are very interested in participating in this effort. So I think we're going to determine what, and they have a track record for working together. We're going to try to determine what's the best way to make that happen. So we have another question. Can you plan to launch a pilot? Can plan to launch. I'm not, Brenda Matthews, your question, I'm not sure I understand, but the current plan, oh wait, maybe it's, oh, so your plan to launch, yeah. So the plan to launch the pilot is, so I intend to announce the charter member group in early January and start to assemble the group to meet, which is kind of a bi-weekly hour-long call. We have numerous issues to work through. The goal is to get the nationwide team off and running in building the implementation that can be shared while we're working through things like IRB, consent. Many of you have participated in the recent survey I sent out on patient-reported outcomes, which we want to collect. The mechanisms for that are fairly broad. So we've got a number of issues that we need to work through, including sort of defining the standard operating procedures and governance of the network. So, my goal is if it takes the nationwide team, some number of months to get this done, they can start testing as we are within their site, as we're then sharing that build with the other sites that are ready to take it. And so, my guess is we'll get to a second site somewhere between 3 to 5 months after nationwide is done. Now, that said, the folks at AI DuPont are actually doing their own effort on this. It's a slightly different path through the common data model. They've expressed their willingness to share things, and so what that will be a great test of is for a group that builds it basically from scratch on their own, make it so that we can actually make sure the data comes together as envisioned to be of the same shape. They're actually already started in their build, and they worked off of an earlier stage of the common data model. So I'm hoping, pilot's going to sort of come online over time, but I think it's going to probably take 5 to 6 months before we have 2 sites entering data, and then I'm hoping that we will be able to have other sites coming online, more rapidly after that. So it's going to be kind of a rolling pilot. I think there's going to be a set of sites that are going to need to wait until the build ends up in Epic, which is a discussion we've been having with them. And other sites, it's going to just take longer for them to get their IT resources sort of lined up and supportive.
Okay, there's 2 more questions. The first one I think is good for Jeff. Epic doesn't currently have a pediatric model system registry. Are we working with Epic to develop a model system CP registry?
We're not working specifically with them on doing that. There is ongoing work there with various sites to develop content and tools for each specialty. I don't think this one is on their radar quite yet. That said, any registry we create as part of this, again, would be shareable with other sites. So we could certainly talk to Epic about using ours as their foundation registry, and in the past they've been very receptive to that.
And yeah, let me add to that so the folks at AI DuPont have have engaged me with their folks at Epic, and the question from Epic was, is there support of this from AACPDM and from the orthopedic surgeons group? would there be support from the Neurosurgical Society? So I think we've got a fair amount of support given the involvement in this network. And so my goal is to work that item to be able to resolve that, so they would incorporate it. Because I think ideally, while it is great to be able to get this jump by including distributing the work that gets done at Nationwide, ultimately if it can end up in the Epic build, that's got some advantages of standardization. May not be able to move as quickly initially, but should allow us to get much broader adoption. And hopefully at the point that happens, there's much less movement in the data model, and because I imagine we'll have to be on a much slower scheduled release cycle of the data model at that stage. But that's definitely on radar to do.
The next question was, does anybody use Allscripts?
Yes, you do down there at Children's Alabama. I do believe of all of the list of sites that I have, I do not believe there is another Allscripts site that's been sort of inquiring about CPRN. Okay. All right, we have a couple more minutes left. I mean, since we've got an august body of people assembled, I'll just leave it open for another couple minutes to see if we have more questions. I don't see any. Oh, yeah, so yes, this webinar is being recorded. It probably will take us about a week to have a link, but I do plan to distribute a link both on the website and to everybody that's participating and whatnot to share with colleagues. And in fact, I should give a shout out to the Hydrocephalus Association, where I've spent a lot of my volunteer time, and the crew that's been on. I know Jenna, and I do believe Jennifer Bouchard, Jenna Koshnitsky, who've been helping put this together and are recording it and are going to upload it for us. I greatly appreciate their support in getting this information out to a community other than the hydrocephalus community. We do have hydrocephalus data fields in our common data model, though. Okay. One last final call for questions.
So not a question. This is Jeff, actually. Not a question, but a comment. And maybe this is, I apologize to Garey for jumping this, but it sort of occurred to me. So I'm curious as, Paul, have you had any thoughts or conversations about trying to coordinate this activity with that going on at Petenet? Or is Petenet not something you're familiar with from Picori?
Yeah, so I am familiar with Petenet. In fact, Garey introduced me to two people involved with Petenet at Nationwide, and now I have a call scheduled, I do believe it's this week, with the PI of Petenet. I was, let's see, I'm just trying to see, I do believe someday, I think it's a day later this week, I have a call with Chris Forrest, I do believe it is, to talk about, is one of the opportunities to sort of coordinate or, leverage pieces, and so to be determined, but scheduled to happen. Definitely a good call. Yeah, no, it's actually on the 22nd. I'm speaking to Chris Forrest in the morning.
Yeah, that's great, because one of the values of Petenet is that they already have a data model, 8 hospitals, lots of coordination, and it may be an opportunity to sort of, if nothing else, learn from their experience on setting one of these things up, if not, attaching somehow to their data model, perhaps even.
Yeah, in fact, I think we have 7 of the 8 hospitals from Petenet involved in this effort. So there would be a lot of sort of benefit of that, and that's part of the reason why I want to talk to him. And, you know, we've been looking at, do we want to do a centralized IRB model, and they've got a whole process for that. And, you know, we're kind of interested in what the consent models are and whatnot. So I think there's tremendous opportunity potentially there. So I am exploring that angle. So I think with that, I'm going to wrap us up. Dr. Noritz, Dr. Hoffman, thank you so much for spending the time this evening. I greatly appreciate it. Everybody who dialed in or didn't dial, I guess it's the modern world, you URL'd in. Thank you. Thanks, Neurosurgical Society Association. Greatly appreciate it, and I look forward to providing the URL in the near future and answering more questions and getting you all engaged. Thank you very much.
Thanks, Paul.
Thank you.